This is LiveWell Talk on COVID-19. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke's Hospital. Today's podcast, I'm going to give an update on natural versus vaccine-induced immunity, the masking guidance, latest vaccine news, including boosters, and Pfizer's recent announcement that its vaccine is safe and effective in children's ages 5 to 11. And also we'll discuss how we can stay hopeful and optimistic during the pandemic that seems to be never ending some days. In the hospital, we continue to see a significant number of the patients admitted to the hospital are actually unvaccinated, and it is about an 80-20 breakdown right now. So of the COVID patients that are in the hospital, 80% of them are unvaccinated. And of those patients, significantly more are proportionally in the ICU than out on the floors. Overall, our COVID numbers are about 20% of our inpatient staff. So 80% of our patients don't have COVID. We're just busy. And we've mentioned that in other podcasts that I think that is directly related or significantly influenced by the shutdowns last year and how colon cancers and diabetes and heart disease kept progressing during that time. It does affect our ability to do elective surgeries because of that paradigm or that observation that shutting down previously may have influenced the volumes that we're seeing now. We don't feel it's a good decision to completely shut down surgeries. So we continue to do surgeries and procedures and have outpatient diagnostic tests performed and workups and outpatient visits. But we have had to be more strategic on what surgeries we select and also whether or not those patients come to the hospital after that surgical procedure as opposed to go home. That's so we can continue to be able to treat traumas and other emergent conditions, which at this juncture we certainly can. Our hospital has not been on ambulance diversion during this recent Delta surge, and we've been able to accommodate all severity of illness that presents to our emergency room. The next update I wanted to give is natural versus vaccine-induced immunity. What's of interest, I think we could tie that into the booster announcement of last week. So the FDA has a committee, the Vaccines and Related Biological Products Advisory Committee, and then also the other advisory committee is on immunization practices. They haven't looked at this yet, but they voted 16-2 not to provide boosters to the general population. And you really have to read the news articles, and they'll come out in print better, more closely than just simply listening to the headline, because they didn't say that the vaccines were unsafe. They just said that there wasn't definitive evidence that they did not cause significant myocarditis and pericarditis in young males. And so they felt at this time that it is not imperative to give the general population boosters. But then they voted 18-0, meaning unanimous, that boosters for those greater than 65 years of age or serious risk factors such as ongoing chemotherapy, solid organ transplants, chronic prednisone at a certain dose, and other immunomodulating drugs for example, Crohn's disease, ulcerative colitis, etc. So out of that data that they looked at to make that decision about the booster, they also found that the vaccines themselves, although they may decrease in efficacy, or let's keep the term simple here, strength, the farther post-vaccination, despite that decrease, they do have still enough efficacy to significantly prevent disease and death. So even though they drop a little bit, and that does account for some of the breakthrough cases we're seeing, it definitely does not have the weakness that would warrant giving a booster. Now, there's some immunologists I mentioned on previous podcasts that they think maybe it should be a three-dose regimen to begin with, and I think that'll be settled in the near future. But I think the bottom line is that the committee that met last week and made the recommendation to the FDA, it's non-binding, it's just considered a recommendation. But historically, they've followed these recommendations quite closely, has said that the booster is not needed because the vaccines are still of a degree of strength that prevents disease and death. The committee also, which I really don't understand what this means, but they said on an unofficial poll, uh, they did also believe that high risk exposed patients and healthcare workers should consider getting the booster. So we're going to have to read a little bit more on that, what actually meant. Is there a further criteria? But I thought that was interesting that 2 of the 3 votes were official and one of them was considered, quote, unofficial poll. We'll have to see what comes out of that. The natural immunity versus vaccine-induced immunity. I think you can look at the Israeli data that's yet to be peer reviewed, and you can take away one solid conclusion from that, is that if you've had COVID-19 and you receive the vaccine, it's safe. So the no harm falls that patient, as long as you're past the recovery period. We won't want to give it to you when you're acutely ill. And I think the Israeli data does study that. The Israeli data also indicated that perhaps natural immunity was stronger than the vaccine, but that data is not as solid as the headlines make it sound. And if you dig a little bit more into the data, it's not as convincing. And I've done that since our last podcast. And so the jury is still out, and it was only Pfizer that was used in Israel, which is of interest because on this country we have it's probably about 60-30-10, 60% Pfizer, 30% Moderna, and then 10% J&J. And I think those percentages are climbing a little bit from the Moderna and the J&J product. But it is becoming apparent that the Pfizer, at about 120 days, this is how the Morbidity and Mortality Weekly Report, does drop from an efficacy of 91% to 77% after 120 days, so 4 months. And if you remember, we talked about the data that we had from some patients that were hospitalized here at St. Luke's. We could see whether or not they were vaccinated. And if they were vaccinated, the average length of time between the vaccination and the COVID infection was 4.6 months. So that 4-month appears to be a marker that identifies some waning efficacy or strength of the Pfizer COVID vaccine. But also during this recent meeting of the FDA, the advisory committee, that Moderna drops from 93% up to 120 days to 92%. So it preserves some degree of strength. So that gap is kind of increasing, and that'll be interesting to see how that folds out as we get more and more data. And we'll certainly keep you up to date on that. The FDA has issued a statement this week that it can be given to children ages 5 to 11. At this time, it's not approved by the FDA for that. And as far as Unipoint Health, and the medical community, we're anxious to get that data, but we continue to adhere to FDA recommendations as we do with other medications, and that has not been granted yet. So we'll keep a close eye on that. I believe it is a smaller dose for the children, about a third of the dose, but I need to see a little bit more data on that and to see just what they mean by. I think they describe it as a robust immune response, and how that translates into protection. That'll be interesting. I think as a physician, the first thing you ask yourself is something safe, and then does something work? And the vaccines are clearly safe, and they clearly have an effectiveness that does influence disease and the possibility of hospitalization and death. And I think we can move forward knowing that the safety and efficacy there are there to protect us. Despite that, there continues to be vaccine hesitancy. And all I can really come down to say is have a conversation with your physician if you're still hesitant, and that they are safe and they are effective. there is breakthrough cases, particularly with Pfizer. However, they do prevent hospitalizations, and if you are hospitalized, the chances of you not being in the intensive care unit are significantly um, higher, meaning you won't be in the intensive care unit if you're vaccinated. I think the boosters to those over the age of 65 and with chronic medical conditions is completely safe and probably warranted, as they may be the patients that will not mount a adequate immune response. Here in the state of Iowa, the masking guidance continues to be a controversy at the school level, at least, but we continue to recommend the CDC recommendations that if you're in high transmission, you should mask in indoor facilities. We've had 3 weekends of college football now, so we'll have to see if that influences, as well as the kids have been back to school, I think 4 weeks now, so that will be an influence at some level, and I think that's yet to be determined. I mentioned in the past that we're past a peak, and I think that's not the correct way to describe it. I think we've peaked, but now it's going to be a significant plateau, much longer than I thought. I was wrong about that. I thought, much like the United Kingdom and some parts of India, that we would have a peak and it would come down quickly because it moves so quickly. The transmissibility of the Delta variant is higher. But one thing that I didn't account for was that, remember, we talked about this before on other podcasts and also in various public forums, that during a pandemic, you have a susceptible bucket of the population, an infected bucket of the population, and recovered. And remember, when we started, it was susceptible as everyone. And we were afraid that just as we wouldn't want everyone to have a car accident, all the car accidents for 1 year happened on a Tuesday, that would overwhelm the system. We didn't want everyone to get sick at once. And that's why we took the measures that we did. So the Delta virus came into the community, and I thought we would have greater protection from the vaccines and wouldn't have the number of breakthrough cases we have. So the actual susceptible bucket was more full than what I thought it was. And I think that's why you're seeing this delayed or this ongoing plateau that stays rather steady in the preceding weeks and is not precipitously dropping. Some of the analytics from UniPoint Health, they have really smart people with really smart computer programs, I guess, and they think that this will go to the end of October. That's yet to be seen. Each day there's some optimistic numbers you see. The wastewater amount of the Delta variant for Cedar Rapids has dropped 2 reports in a row, that's very encouraging. But then the reproduction number will be below 1 for a couple days, and then this morning is up to 1.24, I think, meaning for every case of COVID-19, 1.2 cases develop. So that still means it's spreading. We want that number below 1. I think one of the things that patients and people can do to help with pandemic and hospital volumes is to get a flu shot. Influenza season is coming. We don't know if it'll be a less severe. It will be. We do not know if it'll be a season like last year, which was virtually non-existent here at St. Luke's. But a flu shot will help prevent excessive burden on healthcare and will significantly help with controlling the pandemic as we go into the flu season. I also read this week that the COVID-19 has more deaths than the Spanish flu of 1918 and 1919 here in the United States. So more people have died from COVID-19 than died from the Spanish flu. But I from a historical standpoint, I think there's something interesting about that is that the reason you know why they called it the Spanish flu? This is interesting. So World War I's going on, and neither the Allies or the Central Powers wanted to put into their newspapers that their soldiers were dying from influenza, but the Spanish newspapers, which was a neutral country at the time, wrote a story about it. So it came out to be or reported on it, and it came out to be referred to the Spanish flu when it didn't necessarily have anything to do with Spain from that standpoint. And what was scary back then, and it was that younger people died. And that's always been thought to be because of antigenic drift, and we won't get into that, but the virus had some virility that people with competent immune systems, it was triggered to such a degree that they became sick. And they've gone back and looked at that, and that's probably not what happened. Actually, what probably happened is they saw there was a outbreak or a mild pandemic, if there's such a term as mild pandemic, that occurred in the late 1880s, and they think that people that had it during that time and survived carried over some degree of immunity during the Spanish flu. So elderly patients were disproportionately protected compared to younger patients. And I once had a patient that ran a shoe store in Grinnell when I first started, named Dick Pointer, great guy. And he grew up in South Dakota, and he was well into his 90s when I took care of him. That was 20 years ago. And he's since passed away. But he would tell this story where his job, he's like 8 or 9 years old, and his job was to ride with the town doctor and keep him awake during the day when he was driving from house to house to visit influenza affected families. And it was just a really dramatic story. And it's always sad when an elderly person passes, because the wisdom of all those stories passes with them, and that's certainly something that is to be missed. I was thinking last evening about this podcast, and I wanted to go over some things that I've learned during this pandemic thus far. One is I learned what a pangolin was. I didn't know pangolins existed, but I did learn that. I also learned that Mother Nature and viruses can humble you pretty quickly. Just when you think you got them figured out, and you think you know what direction things are going, they come back and they keep you humble. And that certainly is true, particularly with my recent assessment of whether or not we'd have a narrow peak that has turned in more to a plateau. And I've said it before, and I'll say it again, that I think that we know what we do, we know how we do it, but in times like this, you learn your why you do it, and it's important. If you don't know your why in life, why you do what you do, learn it, because I think that's a valuable lesson, a life lesson, not just for pandemics, but for anything, just to know why you do it. And so learn your why, find it, and I think you'll find a greater degree of fulfillment. Now, the team I work with here at the hospital, they're tired. Uh, it's physically and mentally exhausting to take care of these patients day after day. Each day to come in and to have to calculate, okay, how are we going to do the schedule today so we can accommodate traumas and other emergencies, which we can, as well as take care of elective or scheduled surgical procedures. And they know their why, and that's why they're getting the job done. And I think when we know our why we do stuff, it does keep you going, and it helps each other know that. Um, and part of the why for, I think, any team, whether it's football or military or a hospital staff, is to support each other. And some of the things you do, you do for the sake of the person next to you, and that's important. But I want to assure the community and the listeners that when you see that blue sign with the white H on it, no matter how tired or fatigued we are or how many patients we have, there'll be trained professionals here to help you. And that is one promise to this community that we'll never forget. Thanks for listening to COVID-19 Update. For the latest COVID-19 information, visit unitypoint.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.